Triangles of the neck. Triangles of the neck, as we know, it is considered as one of the very difficult topic because there are too many structures to be identified there. And let's say if there is a cadaveric image based question on this, it becomes really difficult to identify or point out a particular nerve or a blood vessel. But we have prepared enough. We have already have enough arsenal with us to understand this topic. If you have an idea about the muscles of the neck and what nerve is supplying it, which we have discussed in cranial nerves, the cranial nerve which we expect to see in the neck, ninth, 10th, 11th, 12th, what is the location of those nerves? Blood vessels of head and neck, internal jugular vein, external jugular vein, carotid artery, and especially the branches of external carotid artery, and also knowing about the deep cervical fascia. So all these topics we have already discussed. It's time to just put all those topics together and then see how they are seen in the triangles of the neck. And for the PGME point of view and from the clinical point of view, I would say that if you're a first year student, then obviously you need to know that what is the boundary of the triangle, what is the floor, what is the roof, what is the content in that particular sequence. So we will discuss them in that sequence as well. But as a clinician, what you need to know about the triangles is that what structure is coming from where and then ultimately going where. Like if you see a nerve, let's say present in this triangle, it's a carotid triangle. So is it coming from the triangle above inside? And is it going to the posterior triangle there? So that we need to understand, because if there is an injury to that particular blood vessel or to the nerve, then what would be the exact feature you will see here? So many dissections, surgeries of the neck, the radical neck dissections are there. We have to remove the lymph nodes also. So there are loads of surgery in which we have the approach to the neck. So knowing the contents of the neck, because they are very, very closely packed to each other, it's very, very important for a surgeon dealing with this area. So let us start with the very basics first. Let's understand how we classify or divide the triangles in the two major parts, the anterior and the posterior triangle. Then we will see the subdivision of anterior and posterior triangle, and then we'll take individual triangles one by one in more detail. So we'll come back to this picture. We'll be able to identify all these small nerves and blood vessels that you see here, but once you have an idea in a schematic line diagrams. So there we go. For the triangles, again, we have to consider all the triangles of the neck together, because we need to see the structures. They are like passing from one triangle to another, how exactly they reach there. So if I turn my head to other side, again, the upper boundary for all the triangle is going to be the base of mandible, the external auditory canal, the mastoid process, and occipital bone. Again, the same four bony landmark that you will have above. And below the two major bony landmark will be manubrium and the clavicle. So here we go. Let's say this is the mandible, the base of the mandible, the external auditory canal, the mastoid process, and here's the occipital bone. Don't write it, just write, draw it with me. Don't write their name. So we got a mandible, external auditory canal, mastoid process, and occipital bone. Here is the anterior midline of the neck, and this here is the posterior midline. And then obviously we got this manubrium and the clavicle. So we're looking at the side of the neck. If you understand these structures in the neck, that what exactly their course is, from where they're coming and ultimately where they're going, it will be easy for us to fetch the answer to all those clinical questions. And in past few years, they are asking questions from the triangles of neck. They will tell you that there is an injury to spinal accessory nerve or injury to great auricular nerve, that what exactly the features would be. The triangles of the neck are broadly divided by the muscle that is a sternocleidomastoid. So this big muscle here, called as the sternocleidomastoid. Well, we call it sternocleidomastoid because it is having a sternal origin and it is also having a clavicular origin. So we have two head below like this, sternal and clavicular head, and above it is going to the mastoid. So this is the muscle that is a sternocleidomastoid. And the muscle which is present posterior laterally here, that is the trapezius muscle. That is the trapezius muscle. Let's say this one is a trapezius. So we already got an idea about these muscles in the deep cervical fascia. Both these muscles are covered with the investing layer of deep cervical fascia. Both these muscles are covered with the investing layer of deep cervical fascia. So here is the one that is sternocleido, and this one here is trapezius. Please try to write their name in short only so that we have enough space to mark the triangles. And do write it in short along the muscle only. Don't draw a line or something. So this is SCM, and I'm writing TZ for trapezius. So based on this sternocleidomastoid muscle especially, we divide the side of the neck in two triangles. The portion which I'm highlighting right now is called as a posterior triangle. This is the posterior one, which further will be divided. We'll see that. So this whole thing, the highlighted portion here, is the posterior triangle. And one anterior to sternocleidomastoid, it all comes under the anterior triangle. Now, how are we going to divide further these triangles? This big anterior and big posterior triangle, they're further divided by certain muscle. Well, which muscle can divide the triangles? Usually the muscles which are having two bellies. And the double bellies muscle in the neck are whether it is digastric and omohyoid. And what is a common thing about these muscles is they are attached to the hyoid bone. So somewhere in this anterior triangle, guys, let's say if this here is the hyoid bone, just very schematically, that let's say this is a hyoid bone here. So we got a muscle that is anterior belly of digastric. There we go. This is the anterior belly of digastric. And this here is the posterior belly of digastric, which is again going to the medial aspect of the mastoid process. Anterior belly and posterior belly. Let me write them in short again. This is anterior belly of digastric, ABDG. And that's a PBDG, that is posterior belly of digastric. Omohyoid muscle, two bellies again. Superior belly of omohyoid, inferior belly. Superior belly will start from the hyoid bone. It will go downward. It will go deep to the sternocleidomastoid where it is having a facial sling. And then it turns on this side, comes into this triangle and even reaches the suprascapular notch. Omohyoid muscle, superior belly attached to hyoid bone. And inferior belly will go all the way to the suprascapular notch. So this here is the superior belly of omohyoid, deep to the sternocleidomastoid, mind that. And then this is the inferior belly, which is reaching all the way to scapula, to the suprascapular notch. Superior belly and inferior belly of omohyoid. This is how we're going to divide the triangles of the neck in posterior and anterior. So you can see now entire posterior triangle is divided in two divisions. Now we have one triangle above, one below, inferior belly of omohyoid. And if you look carefully, anteriorly we got four triangles now. The anterior part is divided, or anterior triangle is divided into four sub-triangles. Let's name them. So first, posterior triangle. Posterior triangle, guys, if I give it number 1 and number 2. So there are two triangles that you're looking at here, number 1 and number 2. Number 1 triangle, if you see this triangle here, it is in relation to the occipital bone. It is present behind, so we simply call it occipital triangle. This is called as the occipital triangle. And mind it, it is called as occipital triangle, not suboccipital triangle. Suboccipital triangle is at the back. That's a different triangle altogether. There's a triangle at the back also. We're not talking about the back of neck. We're talking about the side of the neck. So this is an occipital and not suboccipital. Triangle number 2, if you look at the location, triangle number 2 is present above the clavicle. So you call it supraclavicular. This is called as a supraclavicular triangle. See, we call it supraclavicular because it is above the clavicle. Now there is another name given to this triangle based on the content. Now what is the main content of this triangle is the subclavian vessels. And that's why it is also known as the subclavian triangle. This is also called as a subclavian triangle. So that's a division of the posterior triangle, the one I highlighted in yellow, occipital triangle above, and supraclavicular or subclavian triangle, which is below. What about anterior? Now, if you look at the anterior triangles, there are 4 triangles I could see here. Let me give them some alphabets here. Let's say this is triangle A. This one is triangle B. This here is triangle C, which is above the hyoid bone. And the one which is below the hyoid bone, let's say this is triangle D. So I'm looking at these 4 triangles. This is triangle A, B, C, and D. So 4 subdivisions of the anterior triangle. So guys, anterior triangle, what is A? The triangle A, probably the most important there, that is the carotid triangle. Triangle A here is the carotid triangle, the one that you see between the posterior belly of digastric, superior belly of omohyoid, and sternocleidomastoid. So that is the triangle A. is carotid triangle. We already have a little idea about the carotid triangle. 5 branches of external carotid artery, we said, are given off in this triangle. Triangle B. Now look at triangle B again. First of all, it is present between the two bellies of digastric. So one name to this triangle could be the digastric triangle. We call it the digastric triangle. Or in other word, the triangle is present below the mandible, right? So all the submandibular structures are here only in this triangle. That's why it is called as submandibular triangle also. So you can call it digastric or submandibular triangle because it is present just below the base of mandible. Triangle C. Now this triangle is a very, very small triangle, and this is the only triangle in the side of the neck which you can see only half when you see from the side. Rest you have like complete carotid triangle, complete digastric triangle, complete posterior triangle you can see on the side. But this triangle which is present here below the mental protuberance, you can only see the half of this triangle when you see from the side here, because this triangle is present here like this between the two anterior belly of digastric of the right as well as left side. So you are just looking at a half of this triangle, and this triangle is called as what? Submental triangle. It is below the this mental protuberance. So this is called as a submental triangle. The triangle is called as a submental triangle. And number D, now look at this triangle D over there, guys. I mean, it may not look like a triangle as such, but if you look at this, it is present below the hyoid bone and it is close to the midline. Now, do you remember something when we said something which is present in the midline but below the hyoid bone, and they were strap muscles? So you have all the strap muscles will be coming from here, like sternohyoid, sternothyroid will be going there, thyrohyoid will be there, omohyoid you can already see forming the boundary. So that means this triangle is mainly about the strap muscles, and that's why we call it muscular triangle. The triangle is referred as a muscular triangle because of the muscles there. So we got a carotid triangle because of carotid vessels, digastric or submandibular triangle below the mandible, submental triangle above the hyoid bone but below the mental protuberance, and then we have that triangle in the midline here, muscular triangle. We just have muscles in it. So out of all these triangles, the one which we have to discuss in relatively more detail is posterior triangle. It's probably the most important, the posterior triangle, and we'll be paying attention more to the carotid triangle. We'll discuss something about digastric also. So with that, let's begin with the posterior triangle first. So I hope you understood the division. So let's now begin with the posterior triangle. Boundary we already know, guys. We already know what the boundaries are. Now I'm going to start with the roof of posterior triangle. Now just like roof of any triangle in the neck, you take any triangle of the neck here, whether it is carotid or posterior digastric, few things are common. Skin will be there, of course. Fascia is there, skin, superficial fascia, deep fascia, and the muscle which is present in superficial fascia, that is a platysma muscle. We know that platysma muscle is all in here, in this region here. So these are the common structure which are forming roof of every triangle there. So something which is to be written as common here is this skin, superficial fascia, platysma. This will be there in the roof of all the triangles. Okay, what else is going to be there? Now let me just take this triangle out of the picture and draw it even more schematically. Now this was the trapezius muscle present on the posterior side. Here we got the sternocleidomastoid. This is the clavicle below, and the muscle which was dividing it in two parts was what? That was the inferior belly of omohyoid. Right, so this is the triangle we are talking about, guys. I don't have to name these muscles again. You can see obliquely placed that is sternocleidomastoid. The one behind is trapezius, the below is clavicle, and the one dividing the triangle is omohyoid, inferior belly of omohyoid. Apart from skin, superficial fascia, and platysma muscle, what else will be there in the roof part? And again, such as clinically important. First, the vein, external jugular vein. Now, we already discussed external jugular vein, which is formed by the posterior division of retromandibular and posterior auricular. When these two veins together forms the external jugular vein, that vein will run superficial to the sternocleidomastoid, will come down in this region, and then pierces the deep fascia to go inside and drain into the subclavian vein. So guys, one thing that you'll see here is the external jugular vein will be coming down all the way like this, superficial to the sternocleidomastoid, of course. and that will pierce the deep fascia there to drain into the subclavian vein. So the first major structure we got here, that is the external jugular vein in the roof. We're talking about the roof here. Second thing in the roof, now a point behind sternocleidomastoid. There is a common point behind the sternocleidomastoid somewhere in the middle of it, where we have 4 cutaneous nerve coming out, coming from the cervical plexus. We have a 4 cutaneous nerve coming out from a point just behind sternocleidomastoid, and as soon as they emerge out, they will all run in a different direction. Like one nerve which is coming behind the sternocleidomastoid will be seen running behind sternocleidomastoid like this. The other one, which is again coming from here, will be seen ascending superficial to sternocleidomastoid and then with the external jugular vein. Other one, which is seen here, is going in front deep to the external jugular vein and goes forward. And the one which you already know goes downward like this and divides into 3 branches before it emerges superficial to clavicle and comes downward here. Remember the supraclavicular nerve we discussed in the supraclavicular space? So the 4 cutaneous nerve. Now before I name these nerves, this point here, guys, this is an important point here. This point here is called as the nerve point. This point here is called as the nerve point. And why this nerve point is important? Because imagine while doing any surgical intervention to the posterior triangle, if a surgeon accidentally incises this point here, the nerve point, it's not 1, it's not 2, you are going to lose 4 cutaneous nerves simultaneously, and there will be a complete sensory loss on the side of the neck, even below the clavicle. So it's a big sensory loss which will take place here if you accidentally incise this point here. So this becomes clinically very important. The nerve point, which is somewhere in the middle of the sternocleidomastoid, behind it, on its posterior border. Well, now the question is, what are the nerves coming out and running in different directions? The nerve that you see goes above and behind sternocleido is called as the lesser occipital nerve. This is the lesser occipital nerve. The one that you see which is going above here is called as the great auricular nerve. Very, very important. That is great auricular nerve. There are loads and loads of questions asked from the great auricular nerve again and again. They are like very specific about asking the question on great auricular nerve, and there is a reason for it. We'll come to that. Great auricular nerve. And please be careful, guys. It is great auricular nerve and not greater auricular nerve. We have lesser occipital and greater occipital. This auricular is one only. We simply call it great auricular nerve. The nerve that you see running anteriorly and deep to the external jugular vein and goes even forward. Now imagine when it goes forward, it will be going to which triangle? What triangle you expect to see here in this part here? We expect to see the carotid triangle here. So that means this nerve is going in the roof of carotid triangle also. And because it is running in this direction, the anterior direction, or you can say the transverse direction, so we call it anterior or transverse cutaneous nerve of the neck. That is why this nerve is called as the anterior. Either you call it anterior or you can call it the transverse cutaneous nerve of neck. Anterior or transverse cutaneous nerve of neck. 4. And this one, we've discussed this in the supraclavicular space. The nerves are called as the supraclavicular nerves. Just let me remind you the supraclavicular nerves which are present in the supraclavicular space. We discussed that in the deep cervical fascia, that there is a space above the clavicle called a supraclavicular space having 2 contents, and you can see both of them. One is external jugular vein coming into that space, and the second is the supraclavicular nerve, the medial branch, the intermediate, and the lateral branch. Remember, the intermediate branch sometimes pierces the clavicle, and the lateral branch was supplying the skin on this anterior aspect of the shoulder. The referred plane of the diaphragm comes in here. So this is about the roof of the posterior triangle. Skin, superficial fascia, platysma. We got external jugular vein, and we have 4 cutaneous nerve. Now out of these 4 cutaneous nerve, the one which is very, very important when it comes to the clinical questions is the great auricular nerve. And they keep on asking questions on great auricular nerve almost every alternate year in a different format. Now one question here is, it's a straight simple relation question, that which nerve in the neck is seen running with the external jugular vein, and that is great auricular nerve. Now let me just first discuss all this information with you, and then we're gonna write them. Great auricular nerve runs with external jugular vein, fine, one thing. Number 2, the same great auricular nerve, it is auricular nerve, so it will go above and will supply the lobule of the ear. So this great auricular nerve is going to supply the entire lobule of the ear, both on the medial and the lateral surface. When you say lobule of the ear, we are obviously talking about lower one third. So lower one third of the auricle, or you can say the lobule part, is completely supplied by great auricular nerve. Number 3, the great auricular nerve is also supplying the skin at the angle of the mandible. It supplies the skin of the face at the angle of mandible. And why this is important? Because when you look at the face, the sensory innervation of the face come from trigeminal nerve. Now, it doesn't matter what branch of trigeminal nerve is that. Ophthalmic nerve branches will be supplying here, like supratrochlear, supraorbital. There was external nasal, there was dorsal nasal. Now, there's so many nerves coming from ophthalmic. Even maxillary nerve gives off branch called as infraorbital nerve coming out and supplying the skin. Mandibular nerve is giving off inferior alveolar nerve coming at us mental nerve, and auriculotemporal nerve supplying here. So overall, the face is innervated. The sensory supply to the face come from where? From the trigeminal nerve, except the angle of mandible. The angle of mandible is the only region of the face which is not supplied by the branch of the trigeminal nerve. It is supplied by which one? Great auricular nerve. So the nerve goes like this. It supplies the auricle, lobule of the ear, and it also supplies the angle of mandible. Now, what is a different way of asking this question again is that they recently gave this great auricular nerve, and there are other nerves which can be injured in parotid surgery. Like if there is a parotid surgery done, if the parotid gland is to be removed, now the nerve which can get injured is, one is obviously the facial nerve which is running inside the parotid gland, right? One that could be that. One is auriculotemporal nerve which can be injured. One could be great auricular nerve could be injured. So all the nerve which are supplying or present around the parotid gland here. So it was remember auriculotemporal nerve supplies parotid gland. So that can be injured. Great auricular nerve which is supplying the skin in this region here. Again we have apex of parotid gland. That also can be injured. Facial nerve goes inside the parotid gland. Even that can be injured. Buccal nerve is supplying the skin here on the cheek region, which is just anterior to the, the parotid gland. Again, that could be injured here. So taking advantage of this information, there was a question asked in the AIMS was that after peritodectomy, a patient has undergone a removal of the parotid gland. A sensory loss was, a patient discovered a sensory loss, but he discovered that sensory loss while shaving. Now listen to this question. I'm just not simply saying sensory loss. Patient discovered a sensory loss on his face or anywhere you can say while shaving. Is due to which nerve might have injured in the parotid surgery that is causing that sensory loss, which he found out during shaving. Shaving is a very important term here. Why? Because if I say the most common nerve to be injured in the parotid surgery, it's auriculotemporal. Agreed. Auriculotemporal nerve supplies the parotid gland, and of course, when you remove the parotid gland, there are very good chances the nerve can be injured. But that's the most common. Think about auriculotemporal nerve is supplying skin at what level, guys? Where does the auriculotemporal nerve supply the skin? It supplies the skin on the temple region here and upper 2/3 of auricle. None of these two area comes under the shaving region, right? The shaving region is this here is the shaving region here. And if you think about this part here, so there comes the great auricular nerve supplying the skin at the angle of mandible. Many people wrote the answer as auriculotemporal nerve, thinking that auriculotemporal nerve is the most commonly nerve injured in the parotid surgery. Fine, accepted. But when the question specifically says that it was found that patient discovered the sensory loss while shaving, then how can we think of auriculotemporal nerve which is supplying the skin on the auricle and the temple? Until unless you are not planning to shave on the temple region, so obviously the answer could not be that. The answer is what? Great auricular nerve only. Another question. I'm going to write all these information for you. Another question here. That is about Fraze syndrome. We're going to discuss that again in the parotid gland. Fraze syndrome, guys. What is Fraze syndrome? Like again, during parotid surgery, if the auriculotemporal nerve is injured, auriculotemporal nerve was carrying the secretomotor fibers to parotid gland. Remember that? I hope you remember from otic ganglion, it was auriculotemporal nerve carrying the secretomotor fiber for parotid gland. If auriculotemporal nerve is injured, so during the regeneration of auriculotemporal nerve, accidentally this auriculotemporal nerve can join with some other nerve. It can join with the buccal nerve. It can join with the great auricular nerve. It can join with the lesser occipital nerve. So any nerve in this region, in this region which is around the parotid gland, it can join with it. And that's how it is started supply. It starts supplying the sweat gland of that region. Like if the buccal nerve is supplying the sweat gland here in the anterior part of cheek. So auriculotemporal nerve starts stimulating the buccal nerve and you start sweating in this region here. If auriculotemporal nerve joins with the great auricular nerve, then it is going to lead to the sweating into this parotid region here, in this region. If let's say the auriculotemporal nerve it fused with the lesser occipital nerve, then you might even see patients sweating behind the ear. So the brain is giving the stimulus for the secretion of the gland, parotid gland, but those secretomotor fibers, because of this wrong fusion, accidental fusion, is either stimulating great auricular nerve, buccal nerve, or maybe lesser occipital nerve. So there's a question here that in Frey's syndrome, when the auriculotemporal nerve, let's say it regenerates, it most commonly joins with which nerve? Is it buccal? Is it great auricular? Is it lesser occipital? And the answer is again great auricular nerve. So you can see there's so many questions which can be asked from this particular nerve only, and that's why it is very, very important. Let me write all these information for you. So what I said is, number one is great auricular nerve. We said it runs with external jugular vein in the neck. It runs with the external jugular vein. Number two, it supplies the skin at angle of mandible. It supplies the skin at the angle of mandible. Number three, it also supplies the lobule of the ear. Lobule of the ear and everything. I mean, it's lateral surface, medial surface, because that is only in the lobule part where everything is supplied by great auricular nerve. When you talk about the upper 2/3 of the ear or auricle, we have a different nerve on the outer side, a different nerve on the inner side. We'll discuss that separately. You can also say that great auricular nerve is the only non-trigeminal nerve to supply the skin of face. It's the only non-trigeminal nerve. Otherwise, it's all about the trigeminal nerve supplying the face skin. It's the only branch which is not a branch of trigeminal nerve, but still supply the skin of the face here at the angle of mandible. And number 5, as we said, in Frey's syndrome. Now, we all know what is Frey's syndrome, when there is an injury to the auriculotemporal nerve during parotid surgery. So, the regenerating auriculotemporal nerve is this regenerating auriculotemporal nerve. It accidentally fused with great auricular nerve, and that will lead to the condition when the stimulus to auriculotemporal nerve leads to sweating on parotid region. So these patients, when they chew, while eating, they show the sweating taking place in this region, because auriculotemporal nerve, which was actually secretomotor to the parotid gland, but now it is also supplying the sweat gland in that region. And as I said, the order of regeneration, the order of fusion, the most commonly fused with what? That is a great auricular nerve is the best answer. Then you can say buccal nerve. It is also chance that the auriculotemporal nerve can fuse with the buccal nerve, which is like you can see the sweating more in the anterior part here, on the buccal region, on the cheek part here, and even with the lesser occipital nerve. But that's not very common. So it can even fuse with the lesser occipital nerve. So guys, all these information are very, very important. See, as I said, we are discussing the triangles of neck, but our focus has to be on the clinical questions. What type of clinical question can we fetch from there? And great auricular nerve is heavily asked from. So ultimately, this is about the roofs. Whatever we discussed here, it is all about the roof here. Skin, superficial fascia, platysma, a vein there, external jugular vein, and the 4 cutaneous nerve, out of which if I'd say 2 important nerve, the 2 most important nerve, one is the great auricular and one is supraclavicular. We already discussed this nerve in the supraclavicular space of investing layer. After roof, now let's move on to the floor. Floor of the posterior triangle. Once again, let me take use of this schematic diagram. Here is the trapezius muscle, the sternocleidomastoid, and there is the omohyoid. So guys, when you talk about the floor is formed by many prevertebral muscles. Knowing detail of these muscles is not important to you. Like one of the muscle that you see in the upper part here is called as semi-spinalis capitis. This is called as semi-spinalis capitis. The caput muscles, these are the muscles which are attached to the base of skull. So we call them caput muscles, semi-spinalis capitis. Below semi-spinalis capitis, you will see another muscle here that is called as a splenius capitis. Splenius capitis. And then comes a huge muscle which is contributing to the floor. In fact, it is the largest contributor to the floor of posterior triangle. And that's why it is an important muscle to be remembered for the question point of view as well. And this is levator scapulae. So third muscle here is the levator scapulae. And let me highlight this levator scapulae. The reason I'm highlighting, guys, because this muscle is having the largest contribution to the floor of the posterior triangle. So this is the biggest muscle that you see in the floor. I'm not saying it is the biggest muscle out of all what muscles we see here. It's the biggest muscle contributing to the floor of posterior triangle. And then we have scalene muscles which are also contributing in here. We have a scalenus posterior, we got scalenus medius, and we have some hidden part of scalenus anterior also. So you can simply say all the scalene muscles in there. Anterior, medius, and posterior. Scalenus anterior, scalenus medius, and scalenus posterior. Many authors don't include the scalenus anterior in it because it is, when you see this triangle, the scalenus anterior muscle is kind of hidden deep to the sternocleidomastoid, so you're not able to see it as properly. But if once you retract the sternocleidomastoid, you can appreciate that muscle also. So I'm just for the sake of naming it, let's say scalenus anterior also. So all the three scalenes, scalenus anterior, medius, and posterior. The common thing about all these muscles is that whether it is semi-spinalis capitis, splenius, levator, or the scalene muscles, these are all prevertebral muscles. And we know that prevertebral muscles are covered with what fascia? Prevertebral fascia. So when you talk about the floor of this triangle, all these muscles, they are covered with prevertebral fascia. They're all covered with the prevertebral fascia. So that is about the floor, guys. Semi-spinalis capitis, splenius capitis, levator scapulae, scalenus posterior, medius, and anterior. You can least expect a question on image-based question on this part, to be honest. Scalenus anterior is important though. But let's say even if they ask, you do remember the sequence of the muscle and you can easily identify it. It's easy to identify levator scapulae. It's a big muscle that you can see contributing to the floor. I'll show it to you. So you can count the two muscles above it and you can see the muscles which are present below running longitudinal downward. Those are scalene muscles. Okay, so this is about the floor, guys, the muscle. And on these muscles, like if muscles are like the floor in the tile, the floor tile, then they're covered with a carpet, and that carpet on those tile is the prevertebral fascia. It's like it is like a carpet on the muscles, and it's very important to remember the prevertebral fascia. You'll see why. Now coming to the last part of this, that is the contents. Contents of this triangle. Like even before writing or drawing those contents, see, whatever you saw in the roof, whatever nerves and vessels you saw in the roof, what was the vessel? External jugular vein was there and the forecutaneous nerve was in the roof. Now the point is where they are coming from or where they are going. Guys, external jugular vein, it goes down and it pierces the fascia to go inside to drain into subclavian vein. So that means it is going inside, that means it is going to the contents. So external jugular vein is not only present in the roof, it is going to be the part of content as well. All the four cutaneous nerve, lesser, occipital, great auricular nerve, these nerves are present in the content. They are all coming from cervical plexus. So they are present as a content and they pierces the fascia to come out and then they spread in different direction. So that means they were the content first, and then they pierced the roof and they came out and running into the different direction over there. So that's why the cutaneous nerve are also present in the roof. So when you write down the content, before I draw that part here, the common content here is again the skin, not the skin, I'm sorry, that is in the roof. The common content is the external jugular vein, great auricular nerve, lesser occipital nerve, transverse cutaneous nerve of neck, and supraclavicular nerve. So these are all going to be the common contents, common structure which are in the roof as well as in the contents. Apart from them, what other contents are there in the roof, in the posterior triangle? Let's draw it. So once again, here is the same thing, the trapezius, the sternocleidomastoid, and here omohyoid, inferior belly of omohyoid. This being the triangle above being an occipital triangle. Now this is having an occipital artery as the content. Now this is how the occipital artery will go deep to the sternocleidomastoid and then deep to the trapezius muscle and goes backwards like this. The artery is what? Occipital artery. I hope you remember, guys, occipital artery. Occipital artery was the branch of external carotid given off in the carotid triangle. It was given off in the carotid triangle and then it comes backward. See, this is what I want you to remember from the triangles, that where it is coming from and then where it is going. So this occipital artery, it starts in the carotid triangle, which is anteriorly. It comes into this occipital triangle and then going even further back. It goes back. The most important content on which the maximum questions of the posterior triangle are targeted to is the spinal accessory nerve. Now we know spinal accessory nerve supplies the sternocleidomastoid as well as trapezius. So that spinal accessory nerve will be entering in here deep to the sternocleidomastoid and supplying it, running backward, and then passes deep to the trapezius muscle also. So this here is the spinal accessory nerve, and undoubtedly the most important content here. I'll tell you why. So it passes deep to sternocleidomastoid, supplies it, of course, runs backward, passes deep to the trapezius and supplies it as well, supplying both the muscle. Sternocleidomastoid and trapezius muscle, these are, we call them as hybrid muscles because they get their motor innervation from the spinal accessory nerve, correct? But their proprioception goes through the C2, C3, C4, especially C3, C4 if I say. So C3, C4 nerves will be taking their proprioception back like this for both the muscle. If I draw these arrows in this direction here, these are what? Proprioceptive nerve to the sternocleidomastoid and trapezius, that is C3 and C4. And they are carrying proprioception from sternocleidomastoid and trapezius, carrying proprioception from sternocleidomastoid and trapezius. That's the major content of the triangle above. Coming to this triangle below, guys, what triangle was below? That was a supraclavicular or subclavian triangle. Just let me highlight that specifically for you. That's a supraclavicular or subclavian triangle. The main content of this triangle is the brachial plexus, the trunks of brachial plexus. So you'll see the upper trunk of brachial plexus, the middle trunk, and the lower trunk, and they're leading toward the axilla. They're going like, then they're ultimately leading to the axilla. That's the trunks of brachial plexus. And of course, subclavian vessels will also be seen. That's why we call it subclavian triangle. So you got a subclavian artery, and more anterior to the subclavian artery will be the subclavian vein, will also be there in this triangle. I'm going to show it to you in the picture also. So that's the trunks of brachial plexus, and here are the subclavian vessels. The subclavian triangle obviously will be having subclavian vessels, artery, vein, both. Subclavian vessels. So apart for the structures which went into the roof, the 4 cutaneous nerve and external jugular vein, these also are the content of the posterior triangle, the occipital artery, spinal accessory nerve, the most important. We got C3, C4 nerve, which are carrying proprioception from both the muscle. In the lower part of the triangle, we have trunks of brachial plexus and subclavian vessels. And see, you got to remember the major structures, guys. If you remember the trunks of brachial plexus, then you think about that what nerves are coming from the trunk. Like the nerve coming from the trunk, we have like dorsal scapular nerve, or the nerve from the trunk is like suprascapular nerve is there. We have nerve to subclavius. So you can expect those nerve to be seen in this triangle also. So rather than mugging up the structures, think about brachial plexus. When we discuss the brachial plexus in upper limb, if a nerve is coming out from the trunks of brachial plexus, automatically that nerve is a content of this triangle. Although nobody is going to ask you that minor detail, but it is just good for your own understanding. If subclavian vessels are there, so some branches of subclavian artery can be seen in this triangle also. Now, before I show you the structures in a picture, now I want to discuss this nerve with you, that is a spinal accessory nerve. We all know about spinal accessory nerve. It originates from C1 to C5. It goes back from the foramen magnum, comes out of the jugular foramen, and then supplies the sternocleidomastoid and trapezius. Now, what is the importance in here? The clinical question which confused many students when the question says that while operating in the posterior triangle, a superficially placed nerve is injured. Now, superficially placed nerve either are those cutaneous nerve, but when you go to the content, the most superficial structure amongst all these, not those cutaneous nerve, superficial structure amongst all these is a spinal accessory nerve. Why is it so? Because rest all the content that you see, occipital artery, trunks of brachial plexus, even subclavian vessels, they are all present behind prevertebral fascia. We saw prevertebral fascia was there in the floor. So all these contents are hidden, or they're protected by the prevertebral fascia. So the prevertebral fascia is protecting all these structures, but not spinal accessory. So spinal accessory nerve is running superficial to the prevertebral fascia. That's a very, very important point to note, that the spinal accessory nerve it is present superficial to prevertebral fascia. In many neck surgeries, we may have to compromise this spinal accessory nerve also. So you got to know that what exactly features could be seen in those patients. So if you're doing any surgical intervention to this posterior triangle, the chances of injury to spinal accessory nerve is anyways higher now, because it is superficial to the prevertebral fascia. Rest of the contents are placed deep to the very thick prevertebral fascia, so they are more protected comparatively. So if the nerve is that way, they even can ask you this question, that spinal accessory nerve is present between which two fascias of the neck? Come on, this is a time for you to think about whatever topics we have discussed, and just try to like amalgamate them together. Spinal accessory nerve is running in this triangle, and it is running superficial to what? Prevertebral fascia. So one fascia is prevertebral fascia, of course. And we already said that spinal accessory is going deep to sternocleidomastoid and trapezius. And we know that sternocleidomastoid and trapezius muscle, they are enclosed in what fascia, guys? They are enclosed in the investing layer of deep cervical fascia. So in a way, spinal accessory nerve is superficial to prevertebral fascia, but because it is going deep to sternocleidomastoid and trapezius, so it is also deep to what fascia? Investing layer. So another important point about spinal accessory nerve is, it is in the neck, it is situated between prevertebral and investing layer. Prevertebral and investing. That's the second important information about the spinal accessory nerve. And coming to the third and probably the most important, that if there is injury to spinal accessory nerve in posterior triangle, then what will be the feature, or what could be the feature that is seen in the patient? The mistake that people do here is that when you think of injury to spinal accessory nerve, the two muscle comes to our mind. One is sternocleidomastoid, one is trapezius, and we start counting the features of both the muscles, which should not be the approach here. Because when you say injury to the spinal accessory nerve in posterior triangle, that means the injury is somewhere here, in this triangle here. The nerve is coming like this and then coming into this triangle and then supplying trapezius. So guys, if the injury is to spinal accessory nerve here, it means the sternocleidomastoid is already supplied, but then it is going to supply the trapezius muscle. So spinal accessory nerve is supplying the sternocleidomastoid first, so which is spared, But because the injury is after it supplies sternocleidomastoid, so only which muscle will be gone? Only trapezius will be gone. They will not say this point, but you have to understand with the language when the question says injury to spinal accessory nerve in posterior triangle means sternocleidomastoid is spared and the muscle which is involved is trapezius. So whatever features you will see in the patient has nothing to do with the sternocleidomastoid. It is all about the trapezius muscle. Let me write that for you. So we're saying that injury to spinal accessory nerve. Injury to spinal accessory nerve in posterior triangle. Injury to spinal accessory nerve in posterior triangle so there is definitely involvement of trapezius muscle, yes, but the important thing is there is sparing of sternocleidomastoid. There is a sparing of sternocleidomastoid. So sternocleidomastoid thankfully is spared, so we will not have features of SCM. So whatever features you will have is because of which muscle involvement? Trapezius muscle involvement. And because of the trapezius muscle involvement, what are the features you will see? The features that you will see because of trapezius involvement. Think about the function of trapezius muscle, guys. Trapezius muscle is having three type of fiber. We have upper fiber, we have middle fiber which are horizontally placed at the back, and then we have lower fiber which are ascending upward. So when you think of the upper fiber of the trapezius muscle, they are responsible for the shrugging of shoulder. So this shrugging is done by the upper fiber. Middle fiber of the trapezius muscle is for the retraction of the scapula. Along with rhomboideus major and rhomboideus minor, the middle fiber also helps in the retraction of the scapula. And upper and lower fiber together, I'm talking about together, when upper and lower fiber, they work together, along with serratus anterior muscle, they also helps in the rotation of the scapula in overhead abduction. I hope you know that first 15 degree of abduction is by supraspinatus, 15 to 90 degree abduction is by the deltoid, but from 90 to 180 degrees of abduction, from here till here, it is done by the rotation of the scapula, and that rotation of scapula is done by trapezius and serratus anterior. But which fiber of trapezius? Upper fiber and lower fiber of trapezius. So that means all these functions are going to be compromised to an extent. Shrugging of shoulder will be compromised, retraction of scapula will be compromised, and overhead abduction will be compromised. But because we have other muscle doing the functions, like there is a muscle for the retraction of scapula called as rhomboideus minor and major, we still have serratus anterior working. So there is not a complete loss. There is just a weakness. Because of the trapezius involvement, guys, there will be, the features will be like we have weakness in shrugging of shoulders, shrugging of shoulder of that side, shrugging of shoulder. Number two, there will be weakness in retraction of scapula. You just have to think about the function of the trapezius and we just got to write it down, the retraction of scapula. Then there will be weakness in overhead abduction. Weakness in the overhead abduction. And the fourth point, which may surprise few of you, that would be, it can also lead to the winging of scapula. Now you might say that winging of scapula is because of the long thoracic nerve injury. Winging of scapula is there when the serratus anterior muscle is involved or the long thoracic nerve is involved in that case. Correct, agreed. Guys, what do you mean by winging of scapula? Winging of scapula is when the medial border of the scapula, it pops out. It pops out from the thoracic wall. That is called as a winging. It looks like a wing coming out here. Any muscle which keeps the medial border and the superior border of the scapula along with the thoracic cage, okay, is an injury to that muscle can lead to the winging. Serratus anterior is inserted along the entire medial border of scapula. That's a main muscle which we say involvement of serratus anterior lead to the winging. But even the trapezius muscle and rhomboids muscle, rhomboideus major and rhomboideus minor, they are also responsible for keeping the upper border and the medial border of the scapula along with the thoracic cage. So even trapezius injury and the rhomboideus major and minor injury can also lead to the winging of scapula. So do not limit the winging of scapula only to serratus anterior. It can also take place because of injury to the trapezius and rhomboideus muscle as well. So these are the features that you're going to see if there is a spinal accessory nerve injured in the neck. Now, how they try to frame the MCQs out of it. In the MCQs, it is very easy to eliminate options in that, because few options there are indicating toward the sternocleidomastoid. We know sternocleidomastoid is not involved here in the injury to spinal accessory nerve in this triangle. So the features, like if let's say the spinal accessory nerve before supplying the sternocleidomastoid is gone, then what would be the features? In that case, the feature would be different. In that case, even sternocleidomastoid is not working. And what is the function of sternocleidomastoid? It helps in the rotation of head to the other side. My right sternocleidomastoid help me turn the head toward the other side. It helps in the ipsilateral flexion of the neck. Okay? So all these functions will be compromised in that case if sternocleidomastoid is involved, but not in this case. So they're simply going to say it like this: a nerve as a superficial content of the posterior triangle of neck is injured in the neck dissection or the surgical intervention in the neck. What will it lead to? So you just have to think about the features of the trapezius muscle, and that's all. Time to look at all these structures in an atlas image. There we go, guys. Now we'll be looking at the composite structures here. So we're like looking at many things in there. I wanted to focus only on the posterior triangle. Needless to say, this big muscle here is a sternocleidomastoid, right? And this muscle here is a trapezius muscle. You can see that is a trapezius muscle. You can see some muscles on the floor. I cannot appreciate all the muscles. They are hidden in between. But I can see the big muscle here. Can you see that big muscle? Let me highlight that muscle for you. That huge muscle over there is the levator scapulae. The one I highlighted, that's the biggest muscle in the floor of posterior triangle, is levator scapulae. And there is one more point which you can add to your notes, that spinal accessory nerve is seen running on levator scapulae. That's how you can identify the nerve and muscle also. Spinal accessory nerve, it runs on levator scapulae. It runs on levator scapulae. This picture is showing me the structures of the roof and content together. Like if you look at the vein, obviously that is what vein, guys? That's the external jugular vein. I hope you remember the formation. That was a posterior division of retromandibular vein, and this is posterior auricular vein. Together they join, and then they give rise to this external jugular vein, which runs superficial to sternocleidomastoid, comes down, and ultimately drains into the subclavian vein. You can see. So without a doubt, this here is the external jugular vein. What nerve we said will be running with the external jugular vein? Look at this nerve running with the external jugular vein. That is a great auricular nerve. Then we said one nerve is to be running behind the sternocleidomastoid. You can appreciate that nerve present over there. Can you see that? Yeah. It is actually running behind the sternocleidomastoid. The muscle is slightly retracted here. That's the lesser occipital nerve. Then you can see a nerve running forward and passing deep to external jugular vein. Deep to external jugular vein. Look at these three branches. 3 branches, 2 branches, doesn't matter. What nerve is that? That's a transverse cutaneous nerve of neck. This one here, this whole thing here is the transverse cutaneous nerve of neck. And look at the set of the nerve which is going down, again dividing into 3 branches. That is the great auricular nerve. This is the, supraclavicular nerve. Not great auricular, that's a supraclavicular nerve. You can see that one trunk looks like supraclavicular, then dividing into 3 branches, coming down and supplying the skin below the clavicle. What other major structures? As I said, we cannot appreciate everything in this triangle. It's a picture from the atlas, so not everything is shown here. But what else you can see? You can see the major content inside, and that is the spinal accessory nerve can be appreciated. That's spinal accessory nerve. And in the lower part of triangle, at least you can see, look at these trunks, guys. These are all trunks of brachial plexus. These are all trunks of brachial plexus, and clearly you can see the subclavian artery and subclavian vein there. Subclavian vessels. Artery is behind, vein is in front. You already know that subclavian artery is divided by the muscle called as scalenus anterior. So that is a subclavian artery which is behind. Subclavian vein is in front of the muscle. Subclavian vessels are to be seen. So most of the contents we can appreciate here in this picture here. We'll be using the same picture to appreciate the content of the triangle which is in front. You can see the carotid triangle, and the important thing is to understand this connection. What comes from here and goes in here. That is the important thing here. So this is about the first triangle, that is the posterior triangle of the neck. Very, very important, especially two nerves. One is the great auricular nerve on which you get questions, and one is the spinal accessory nerve, the two nerves on which questions are heavily asked.